Hello,
Good
good evening, ma'am. Good evening, good evening. Welcome, welcome,
evening.
ma'am. And thank you for taking out your time for this session. Ma'am, Dr. Kakkar is here.
I think so. I've just asked sir on the phone to join. So I was just seeing if our voices are clear and if everything is going well. Just checking.
Right, right. Okay.
Good evening, ma'am. Good evening, Guru ma'am. Good evening, Ranga sir. Good evening, everybody who's joined. We are just waiting for Kaka sir to join. Good evening, Kaka sir. Thanks for
Good evening, sir.
joining.
Sir, please unmute yourself. Kakkar, sir, please unmute yourself.
Yeah, can you hear me now?
Yes, yes, sir. You're audible.
I can see Dr. Pasi also.
Yes, yes, sir. He is also joined. So please unmute yourself.
Dr. Pasi is on a mute mode.
Yes, yes. Can you hear me now?
Yes.
I can hear you now. Seeing you after a long time.
Good evening. I ditched you last time.
I know. I'll talk to you later. वो बाद में निपटूंगा मैं.
Okay. Sure.
So you're in the car. You are driving back.
Yes. I have still not reached home.
Oh, good.
Okay, sir. So I'm waiting for Dr. Satish Jain sir to join.
Okay.
I don't know whether
Can you, Dr. Raman, can you introduce us to those who have already joined?
Sure, sir. I'm just waiting for Dr. Satish Jain sir to join.
Meanwhile, you tell us who others have joined already.
Okay. So, sir, I can see Dr. Vikas Kakkar sir is there, and Dr. Ashima, she has joined, the moderator for today's session.
Yes.
And
Hello, Ashima.
Good evening, sir. Am I audible?
Yes. Hi, Ashima. Nice to see you.
You are very committed to the purpose, sir. You are in your car, you're traveling, and still you're logged in.
Of course. Why not? When Ashima is there, I will always lock in. So, Ashima, what is the news from Dr. Satish Jain?
The sir will be joining us shortly.
All right. So, Dr. Raman can brief us. Let Dr. Vikas Kakkar start the proceedings. He can just brief us about what all is going to happen.
So I'll just say one thing. As we all know, the adequate knowledge of the surgical anatomy forms the basis of good method surgery. And we also know this thing, the temporal bone is one of the most complicated areas in the human body. And so is the radiology. It has never been my favorite topic. And I have found it always difficult how to read the CT scan, to be very honest with you. So I think it's a very good thing that has started with the efforts of our president and secretary, and Dr. Raman Sharma has taken the lead. And Dr. Ashima is also equally involved in that. So with the efforts of these two persons, I think they are doing a commendable job. I must congratulate them for this wonderful series of. And we cannot think of a Gen on the radiology of the temporal bone, and shortly he'll be joining us, and rest I think he will explain everything about it.
Right, sir. So good evening, everyone. I welcome you all in this fourth session of our academic module, which we are running under the aegis of Haryana AOI. So I'm Dr. Raman Sharma. And
I think Dr. Satish Jain is joining. He's joining.
Yes, sir. He's joining.
So just ask him to unmute.
Yes. I request all to please unmute yourself, mute yourself to avoid any disturbance during the session. Good evening, sir. Dr. Satish Jain, sir. We welcome you. Sir, you are not audible. Satish Jain, sir. Hello, Satish, sir.
Hi.
Hello, good evening, sir. Good evening, sir. Welcome.
Good evening. Good evening, everybody.
Good evening. So, sir, I was telling about this session that this is our fourth session of our academic module, which we are running under the aegis of Haryana UI. And I'm Dr. Raman Sharma. I'm assistant professor at Maulana Azad Medical College and chief coordinator of this program. I would like to thank all my participants, all the candidates, for their consistent support and participation in this academic activity. And I also thank all these senior faculties for taking out the time to make it a successful academic event. So everyone knows that today is the session on radiology, which will be taken by Dr. Satish Jain, sir, the radiology of the temporal bone. So with this, I would like to introduce the moderator for today's session, Dr. Vikas Kakkar, sir. Sir is head of the department at SGT Medical College, Gurgaon. And I would like also to introduce our second moderator for today's session, Dr. Ashima Saxena. Madam is consultant at Sri Ashwini Saxena Hospital at Rewari. So I request my moderators to please introduce the guest faculty for today's session, Dr. Satish Jain, sir. Thank you.
Good evening, Dr. Satish. Can you hear me?
I think sir is having some difficulty with the mic. So please adjust it.
I think let him join.
Yes, yes.
I think meanwhile, moderator can keep us busy if somehow some anecdote or something regarding radiology, of course, not anything else.
How many PG students are there? Is there any number? Raman, can you?
We have
Total
65 people logged in right now, sir.
Total 65, participants are there.
Wow, that's a big number.
We expect more, because last time we had about 90 odd.
Okay.
So
People will be shortly joining.
Yeah.
So I think this time we will outnumber the previous lecture.
Yeah.
So Dr.
There is
Swendra
also
Singhal
a
is now.
YouTube link so that if there are more participants than 100, then they will shift to the YouTube link which is getting live streamed at the moment.
Good evening, sir. Good evening to all.
Good evening. Good evening.
Sir, Dr. Singhal is busy in convocation today. He will not
Yes, sir.
join today. Sir.
Okay. We'll be missing our president.
Yes, sir.
Our till that time, I must congratulate you for your wedding anniversary.
Oh,
Do you know he
Thank
has
you.
celebrated his 25th Silver Jubilee wedding anniversary?
Thank you very much, sir. Thank you.
So it was yesterday or day before yesterday?
Sir, it was on the 8th.
8th.
Yes, sir.
Only 3 days back.
Yes, sir.
Rupinder,
So-
what is the secret? How did you manage 25 years together?
Sir.
He has not managed, she has managed.
Yes, sir.
It's one of the same thing. He is in
Dr. Saroj manage everything, sir.
Okay.
We have just do this ENT, OPD and OT, nothing more than that, sir.
So that's how yes, it has been managed.
ENT is my passion.
Ah.
And I'm spending good life with Dr. Saroj and with children, sir.
Yeah, that's great.
अभी रुक लो, इसका तो मैं डॉक्टर रुपेंद्र का डांस नहीं देखा.
दिखाते नहीं है यार, हम ही डांस करते रह जाते हैं जगह जगह. हाँ, हम ही डांस करते हैं, आगे आगे कर देते हैं, डांस कराते हैं. ये कहते हैं कि भाई ENT सर्जन से ज्यादा तो ये डैश हो गया.
Dr. Bhargav, you are busy fellow. I'm calling you again and again, inviting you again and again to Bhiwani, but
नहीं यार, आऊंगा. देख, ऐसा है कि ऐसे कोई बिजी तो नहीं है, कोई बिजी नहीं है. अगर बिजी बोलूंगा तो ये झूठ होगा, ऐसी कोई बात नहीं है.
Rupinder put me on duty for that.
हाँ, ये
Okay, sir. We
मेरे
will
को
invite you shortly, sir.
मेरे को दोनों तरफ कैरी करना पड़ेगा, पहली बार तो होश में फिर बेहोश में।
नहीं, sir.
है ना?
We will take care of two conditions, sir. No
हाँ
problem.
हाँ ठीक है, कोई नहीं। Hello. What about Dr. Satish Jain? Has he joined back or
He
is
has
he?
joined,
So
probably
he
he
is
can
joined,
come.
but there is some issue with the audio. So he's managing that.
Okay.
So,
We
so
can see
meanwhile, I
him.
would like yes, we can see him. I would like to tell all our PG's students who have joined this session that this radiology of the temporal bone is very, very important for your MS exam. Every one of you is going to get the HRCT temporal bone, and you will get different kind of questions. So I would like to ask our senior faculties, our senior examiners over here.
Hello.
So what is yeah?
I think
sir, good
Dr.
evening.
Satish has come back.
Yes, yes.
Yeah.
Hello.
Vikas, take over.
Hello. Yes, sir.
Good
You're
evening, Dr.
audible.
Satish.
Yeah, am I
Good
audible,
evening.
sir?
Yes, sir. You're audible.
Yes, yes, you are audible.
Thank
Audible
you so
now.
much for your patience.
Hi, Satish.
Hello, sir. Good evening. How are you?
Good evening. Very good evening. First of all,
Audible
we must
clearly, sir.
thank you for sparing your valuable time and sharing your knowledge and expertise with all of us.
All thanks to you all Haryana AY people, the association and the big guns. I can see Vikas Kakkar sir, Pasi sir, Rupendra Ranga sir, and so many, all stalwarts. And thank you once again for giving me this opportunity to share with you all.
It's always a pleasure to listen to you and see to you operating.
Thank
I have
you
been
so much,
asked
sir.
to introduce you. You don't need an introduction. Everybody over here needs to everything
Your
about you.
students. Your
But
student is the biggest introduction.
I would like to share a couple of things with all the participants. One thing, he is having an auditorium in his hospital, and he has named that auditorium by the name of Dr. A.B.R. Desai. That is the respect and regard students give to his teachers. As secondly, I don't know whether you remember or not, few years back, one thing, whenever I am in Jaipur, I always go to Jain ENT hospital. So a few years back, I was there and he had good couple of surgeries and I watched all those surgeries. Then he started with OPD and he finished the OPD around 11:30. And then he asked me, sir, ghar chalte hain ji. I went to his house, had a couple of drinks. At 12 o'clock at night, Gaurav Medikri was there, whether you remember or not.
Yes, sir. Yes, sir.
And he called Gaurav, let us do some academics. मैंने 12 बजे कह दिया, बॉस मेरे को खाना खिलाओ और मैं सोना चाहता हूँ. And he started the academics right at 12 o'clock at night. I don't know at what time they finished. And next morning, 8 o'clock, he was there in the hospital again. And he took his shower also in the hospital. So much dedicated and committed he is to this profession. One more thing I would like to share about him. He has got a huge library in his house. So I have never ever seen such a big library in any individual's house. Rest, Tish will tell us about this library also, how many books does he have and how many journals he has. But that was something to watch.
So the moral of the story, Vikas, here is that academics is always better after a few drinks.
The alcohol always works.
So anyway, sir, I think we will start now because
Yes,
being a long session, so we want to finish in time.
yes, sir.
And Dr. Satish Jain, I'm Dr. Bhargav here, and welcome to you. And let's start off.
Thank you. Thank you once again. And I can see Pasi sir also on the screen. Thank you,
Yes,
sir.
yes. Good evening. Good evening. Please
Good
carry on.
evening. Good evening, sir. Thank you so much, sir. So, as the topic today for the discussion is radiology of the temporal bone. We all know temporal bone radiology is very important. Many times, like we discussed last time for the CT scan. nowadays the dimension of, looking at radiology is totally changed for the region for trying to get more and more information for our surgical point of view. Are you getting something on the screen, sir?
Yes,
Yes,
we are
sir, we
getting.
can see.
CT scan?
We can see.
We can
Are
see
you-
MRI, sir. MRI.
MRI or CT scan?
MRI we can see.
Oh, let me share the CT. Uh, now,
Yes, sir.
do you see the
Now
CT scan?
it is, yes, sir.
So first, I know there are a lot many junior colleagues, with us in this seminar. CT scan temporal bone is a very, very useful information. Gives useful information regarding three-dimensional anatomy of this, one of the most complex bone of this body. This is not only single bone, but there are a lot many ossicles suspended in this bone, and so many important structures traversing from bone to the extracranial structures, carotid artery, facial nerve, jugular bulb, so many other things, with some millimetric distances from the critical areas from our disease and everything. So here, some millimetric anatomy can change the entire scenario. And that's what the utility of the radiology, to give us that information pre-op. So CT temporal bone is very, very useful in diagnosis. Not many of times for the diagnosis, but yes, it helps in difficult situations. But more often to give us surgical information in terms of giving three-dimensional anatomical information and in differential diagnosis. This is very, very important in preventing complication. So first of all, what kind of a CT scan we should order in our practice to get maximum information and how to look at it in different situations. So the best, like I said in the PNS talk, we should have DICOM files. We should order 0.5 mm, 0.6, whatever available your radiologist, but minimum 0.5 mm CT scans in axial plane, and rest your software will reconstruct so that we can get three-dimensional information. Rather than getting into printouts which do not give dynamic information, this DICOM files give you three-dimensional information. Like PNS, there are certain structures which are best seen on axial sections, certain on sagittal, certain on coronal. Similarly, here in temporal bone as well, the onus on the surgeon is to look for those things which are best seen in particular sections, which I'm going to discuss with you. So how to look at CT scan, that is second most important thing. See, when you get a CT scan for a, suppose, autosclerosis, where you actually need a CT scan to see any anatomical abnormality, not for diagnosis of autosclerosis, the radiologist will report in one line, normal study of CT temporal bone. Radiologists are too busy reporting their, brain CT and other abdomen and other CT rather than giving time on a temporal bone and PSS, which is fine, some millimetric details need to be addressed. We have given earlier couple of times to various radiologists or proforma to give us complete information. That proforma carries more than 300 points, which radiologists cannot, afford to give that much of time. And they straightforward refuse. So ultimately, my point is the onus is on the surgeon to look at CT scan in different perspective in different diseases. That's what I'm putting forward in temporal bone without wasting time. So first of all, how to look at the CT scan? See, on the left corner, this is 0.7 mm scan. By every move, my slice is going to be run by 0.7 mm. Every time it is going to skip 0.7 mm. In temporal bone, when we order the CT scan, according to the pathology, accordingly we need to look at the structures. For example, if I am suspecting autosclerosis, I need to look at the CT scan from autosclerosis perspective. What are the things which can change my diagnosis from autosclerosis? what difficulties I can encounter in otosclerosis surgery, those I need to look at, like any prolapsing facial nerve, any incus fixation, malleus fixation, anterior atic fixation, any possibility of persistent stapedial artery, all those things which can complicate your course of otosclerosis surgery. You need to look at those situations. In cochlear implantation, we need to look at different perspectives. In CSOM surgery, in cholesteatoma surgery, we need to look at different perspectives. So it is important why you are looking at CT scan. So let me tell you one by one. This is axial sections. I will keep pointing out what situations or what anatomy is best seen in coronal, what anatomy is best seen in sagittal, and why it is important. For example, imagine I am looking for the otosclerosis, number one. See, this is coming from top to bottom. This is axial section, this is anterior, this is posterior. I am coming down. Now see, this is tilted picture. This is the petrous body which is coming and the petrous cells. Now see on this side. The first, see this, the first important structure coming from above, the topmost structure in the temporal bone is superior semicircular canal. And if I go down, see, this is the anterior limb, this is ampullary end, this is non-ampullary end of the superior canal. This is a very, very important structure, as we have seen in our practice, couple of cases of superior canal dehiscence syndrome presenting as conductive hearing loss. Normal tympanic bone, everything normal. And when the exploration for the otosclerosis, exploration for the stapes surgery done, the ossicular chain was found mobile. Normal middle ear finding, and ultimately we had to close it back. And when we went to CT scan, it was actually a superior canal dehiscence, which can present with a conductive hearing loss in the lower frequencies. CT scan can easily rule out. But see, even if there is dehiscence in the axial sections, you cannot make out. See, you need to see upside down picture. Now see what I'm doing. I'm converting to coronal. The same CT scan, I am converting to coronal. And then I will show you, see this. Let me show you. See, this is vestibule, and these are all the three canals. Can you see? This is vestibule. This is the lateral canal going laterally, covered by the thick bone. This is superior canal going up, and this is posterior canal going behind. Now see, if I follow dynamically, look at the bone over the superior canal. I am following the entire course. Following the entire course of the superior canal. See there? We should carefully see if some bone is dehiscent over it. See, this is the way to look at the superior canal dehiscent. You can see on the opposite side as well. See this, where my cursor is. There is a thick bone over the superior canal. Can you see very clear? That rules out a possibility of a superior canal dehiscence, which one can easily overlook. And if there is a superior canal dehiscence associated with otosclerosis, superior canal dehiscence is what? Is the third window in the intact labyrinth. Labyrinth has normally two windows. The sound coming preferentially through the ossicular chain to the whole window goes in, and because of the movement in the fluid and the baffle effect, round window comes out. And there is no other leakage of sound energy anywhere in the vestibule. Now, if there is a superior canal dehiscence, what happens? There is leakage of sound. So sound coming through the whole window is not able to, mobilize the inner ear fluid because it is leaking somewhere. So there is inner ear conductive hearing loss. Now, if it is a big one, it can give symptoms, vestibular symptoms, auditory symptoms. I'm not going in detail. But if there is associated otosclerosis, what can happen? If the stapes is not mobile, there are only two windows working. Stapes is fixed. So only the round window and the canal dehiscence is working. And moment you do the stepidotomy in such cases, the third window becomes functional. The patient who was not symptomatic now becomes symptomatic. The moment you open your oval window, the third window starts functioning and the patient who was asymptomatic becomes symptomatic. So you have to be very careful in diagnosis of superior canal dehiscence. It is very important. That's why in autosclerosis generally, CT scan is not mandatory. But this is one surgery when the patient comes with a conductive hearing loss, and if you are not careful, if you are not aware of the anatomical abnormalities like this, patient can develop sensorineural hearing loss, which is something not, nobody wants, even the patient or a doctor. This is one of the most rewarding surgery. So it is always better to have a CT scan to rule out all such possibilities. Number one. Now, as I'm going down, see this going up. This is the non-ampullary end. I am following the non-ampullary end, non-ampullary end, non-ampullary end. And this non-ampullary end continues as the ampullary end of the posterior canal. Because non-ampullary end of the posterior and superior joined together. So this is posterior canal now. Coming back up, this is the ampullary end. So these are two ends of the superior canal we must see now coming down. Now see, the most important thing coming is the intra-auditory meatus. Can you see this intra-auditory meatus?
Yes.
This dimension of the intra-auditory meatus is very important for many surgeries. Many surgeries means if you are doing autosclerosis, if you are doing cochlear implantation, both you need to see any change in dimension of the intra-auditory meatus. If intra-auditory meatus is too big, see with this, with this software, I can measure the distances in sub-millimetric accuracy. See this, I can measure the dimension of the intra-auditory meatus at various level. If it is too big, can be a problem. Too big means there could be direct communication between the intra-auditory meatus and the inner ear. And that is the sole source of CSF gusher. Earlier, it was assumed that the cochlear aqueduct could be one of the source of CSF gusher. Not a single case so far has been reported where the cochlear aqueduct has been attributed as a cause of CSF gusher. It is the direct communication of the subarachnoid spaces containing CSF from the intra-auditory meatus to the inner ear space. And see what is there? Blocking this. This is cochlear aperture. Can you see this cochlear aperture? This is important where this is the modulus and all these things blocking the communication direct flow of CSF to the inner ear. And this is important to see both in autosclerosis surgery as well as cochlear implantation surgery because it can lead to gusher otherwise. Many a times, if you are not aware, if you don't have a CT scan, you are doing a stapes surgery and can lead to gusher if the intra-auditory meatus is too dilated. What happens? Many times we have seen where we didn't get the CT scan done and we came across the gusher. There was conductive hearing loss on audiogram, sort of mixed type of a hearing loss with conductive component. Because of this direct communication of the inner ear, the CSF fluid with the inner ear fluid, giving a situation of inner ear hypertension. More inner ear pressure with the foot plate mobility is reduced, giving false conductive hearing loss. The moment you open the inner ear, and there is a gusher. And those are the patients which eventually develop sensorineural hearing loss. Those are not the candidate for stapes surgery anyway. So the CT scan can prevent you from a major problem if you are very aware. So what you need to look at? Intra-auditory meatus dimensions. This is very important in stapes surgery as well as cochlear implant surgery both. Then the cochlea and vestibule. See this. This intra-auditory meatus leads to various nerves to the cochlea, vestibule and inner ear. So if I see superiorly, the anterosuperior nerve which is leading in the facial nerve, can you see very clear? The facial nerve leading from the anterosuperior part of the intra-auditory canal. If I follow this, this is the first genu. First genu. If I follow this, this is the horizontal segment. If I follow further, that is the second genu. This is the mastoid course. Follow my cursor. Mastoid course, mastoid course. This is mastoid course. And then ultimately it comes out from the stylomastoid foramen. Now, if I'm coming back, see now, coming back, just above the stylomastoid foramen. See this, just above the stylomastoid foramen, a small nerve emerged from the facial nerve. See carefully. Follow my cursor. I am following this small nerve, going to the, see this, going to the medial edge of the medial end of the axon meatus. This is chorda tympani. And this space between chorda and the facial is the facial recess. This is very, very important to know from the cochlear implantation point of view, not from stapes and other point of view, because this gives one of the most important access to the posterior part of the middle ear through the mastoid, known as posterior tympanotomy. And in every case, if you look like this, you can measure the dimension of the facial recess. See, this is almost 3 millimeter. And this is very important and information in the cochlear implant surgery, whether your dimension of the facial recess is adequate. Though it is not very much malformed in any given situation, the reason being, at the time of birth, the dimension of the middle ear, inner ear, and the facial recess are same as of adult. Newborn has the same dimension of the facial recess as the adult. It doesn't change. Middle ear doesn't change, inner ear doesn't change. What all changes is the mastoid and the axon-auditory canal dimension, not the facial recess, middle ear and inner ear. So this facial recess you can pick up from the CT scan, from this dynamic CT scan. You cannot pick up in the CT scan plates. You know, when we talk of CT scan, it should be dynamic only to give us most adequate information what you can think of. So this is facial now. We have seen this horizontal, all the portions of the facial now. This is very important from various surgical point of view. You know, this is the first genu. In stapes surgery, this is important whether your horizontal segment is prolapsing down over the oval window. If you are not aware of this information pre-operatively in otosclerosis surgery, you can see this as a surprise when you explore the middle ear. And how can you see best? This is axial section. If the nerve is prolapsing from above down, you need to have this information in the coronal section. See now, so important you yourself can see. See this. See, this is ossicular chain. Let me show you ossicular chain in the coronal section. See this malleus, this is incus, and this is stapes going to the oval window. This is oval window, this is vestibule, all the three canals. Now see, this is ossicular chain, malleus, incus, and the stapes. Stapes crush. Can you see very clear? Going to the oval window, and see, here is your facial now above that, above the level of the oval window. In any given situation, if your facial nerve is prolapsing, you will see this facial nerve prolapsing down over the whole window. And if you see this kind of a situation pre-op, it all depends upon your experience, how you counsel your patient. Majority of the time, what we have practiced in a setting, you know, yeah, obviously you have to be extra careful, otherwise it may result in facial paralysis, palsy, paresis, whatever in handling the facial nerve. So you have to be very careful in counseling your patient that this kind of a situation will require some sort of manipulation of the facial nerve, which can result in weakness. And if we are not able to get adequate space and put a piston, we may have to abandon. If you don't have this information, you will see intraoperatively as a surprise, and then you have no option but to abandon because you can't counsel your patient adequately that time. So this is so important to see. See, this is facial now. See, this is facial now, that where the oval window, this is the stapedial crust, and this is facial now. Above the level of the oval window, this is the oval window, above the level of the oval window. So this is very, very, you know, useful, vital information as far as the facial nerve is concerned. So facial nerve, the entire course, we must look in various pathologies. This is horizontal segment. This is not uncommon to see the horizontal segment dehiscences. In cholesteatomas, Many a time patient comes with a facial palsy. With a good CT scan, you can get to know where the cholesteatoma is actually involving the facial now. And accordingly, you can plan your reconstruction or whatever you intend to do on the facial now. But that information is very, very vital. So the first nerve, what you see is the facial nerve, and the other side is the superior vestibular nerve. This is vestibule. This is cochlea. And this is the third nerve. This is cochlear nerve. This is inferior vestibular nerve going to the, see, this is posterior semicircular canal. And this is one of the singular nerve, what we call it, singular nerve going to the posterior canal. On a good fine CT scan, you can pick up so well singular nerve. This is singular nerve. This is inferior vestibular nerve. This is cochlear aperture leading to the cochlear nerve. This cochlear aperture has a significance in various surgeries to know. Number one, in cochlear implantation. If this cochlear aperture is too widened, there is high possibility of a gusher. There is high possibility of a, direct communication of the CSF space with the inner ear space. If this cochlear aperture is very narrow, there is a high possibility of being a, thin cochlear nerve. And that you have to give a guarded prognosis to those patients. If you have a thin cochlear nerve, that may not be adequate to transmit the sound, though still it is not a, a direct contraindication, absolute contraindication, but yes, this is something you need to counsel your patient well. Now, the third important information as we go down from here is the anatomy of the cochlea and vestibule. Malformations in the inner ear are not uncommon. In cochlear implantation, this is very, very important. As in embryogenesis, the cochlea starts as an otocyst and then matures. Wherever, at what point of time during that, during embryogenesis, at any point of time, if the developmental arrest happens, that kind of a cochlear anomaly ultimately patient has. If this cochlear development starts at the 3rd week of gestation and it continues till 25th week, and majority of the development of the cochlear morphology happens to occur from 3rd to 9th week. Suppose there is a developmental arrest at the 3rd week, there will be no cochlea, no vestibule. Suppose there is a development at the 4th week, then this otocyst enlarges to become a common cavity. And at that time, if the development arrest occurs, the patient will have finally a common cavity. Then it differentiates into cochlea and vestibule. In the 5th week, if developmental arrest happens, there could be separate cochlea and vestibule with no internal architecture. So there are a variety of cochlear malformation which develops, and accordingly you can see on the CT scan, and accordingly your strategy of the cochlear implantation changes massively. There are anomalies like IP1, IP3, common cavity, which has a high possibility of a CSF gusher, and you need to plan your surgical technique accordingly in those patients. Like we do a subtotal petrojectomy implantation with a complete obliteration of the cavity to prevent any future possibility of a gusher. So you have to be prepared according to the anomaly of the cochlea. In otosclerosis, you need to look at the cochlea differently, because cochlea can be involved in the otosclerotic process only. If the cochlea is involved in the otosclerotic process, then you have to identify that situation, cochlear otosclerosis, and accordingly plan your surgery and the post-operative medical treatment. Because those are the difficult patients in terms of, giving good outcome. Those are the patients who require long-term medical therapy to prevent this process of osteogenesis and osteolysis. And third is, you need to take a call finally when there is profound sensorineural hearing loss. Even your stepidotomy and hearing aid doesn't work. And if there are massive changes in the cochlea, to do a cochlear implantation. Even in the massive otosclerotic patient, we have done a couple of patients, cochlear implantation and doing well. So you have to identify those changes in the cochlea. See, for example, I'll show you. See the normal bone, normal petrous bone around the cochlea, the dense bone. Now, if the patient suppose has a cochlear otosclerosis, how will it look like? How it look like? Let me show you. How does the cochlear otosclerosis look like? See this. See this particular patient has a massive cochlear otosclerosis, and we recently did a cochlear implantation in this patient. See this. You saw in the previous cochlea the dense bone around the cochlea. Now see the entire bone around the cochlea is hollowing out. There are multiple halos around the cochlea. That signifies the cochlear otosclerosis. And you can imagine how difficult is going to be the cochlear implantation in this scenario. See this? This is the basal ton, and this is completely, involved by the otosclerotic foci. Once you open the round window, open the area surrounding the round window, you will find a whitish bone. You have to clear that bone to enter into the cochlea like this. So that those are difficult patients. Sometimes the otosclerotic process involves the entire cochlea, and you may have to do a massive drill out, sometimes complete drill out. So all depends upon the CT scan position, but it starts at the basal ton and then spreads everywhere. In this particular case, the involvement of the basal ton by this otosclerotic process, which we could clear up, drill out, and then rest of the cochlear lumen was good. See, rest of the cochlear lumen was good. Only the basal ton beginning was involved, which we could clear off. So this is how you need to look at the cochlear otosclerosis, because sometimes this is one of the major problems you come across. Okay. Yes. Now, yes. So coming back to the same scan, you can see the cochlea. Sometimes the vestibule is dilated. You have to be careful, as one of the syndrome is an enlarged vestibular aqueduct syndrome. Enlarged vestibule, enlarged vestibular aqueduct, all those things to be carefully, addressed. See, this is the vestibular aqueduct. At the posterior edge of the vestibule, at the posterior edge of the petrous bone is a thin canal. The inside of the vestibular aqueduct is like a thin hair you can pass through. And see, this opens in the vestibule here. So this vestibular aqueduct, dimension of the vestibule, all are important while doing stapes surgery or cochlear implantation, as if you are not aware of this, can lead to gusher, and you have to be prepared to deal with that. So all this anatomy is important. Then comes to the ossicular chain. This is very important, not only in stapes surgery, not only in CSOM surgery. Many times you may have ossicles eroded, and this kind of information you can get very well from the CT scan. See this. This is anterior-posterior information. This is your head of the malleus. This is your incus. Many times we have seen in patients with conductive hearing loss explode for the otosclerosis, had incus fixation to the wall, bony fixation of the incus, bony fixation of the malleus anteriorly. And this is very important. You can see the entire ossicular chain. See this entire malleus, incus, and see, this is the stapedial arch. This is the stapedial arch, and this is the includo-stapedial joint. This is in a good CT scan, you can have complete information of the entire ossicular chain when you are suspecting ossicular disruption or any other abnormal fixation of the ossicle. Last year only we did 2 cases of where the malleus was fixed in the atic. Completely fixing the ossicular chain, pure conductive hearing loss. And how to pick up that? In the coronal section. See in the coronal. See the coronal, upside down. This is malleus. And this is suspended with the superior malleolar ligament. If they get ossified, there is a bony lamella which is, attaching the malleus to the, roof of the atic, and leads to fixation of the ossicular chain. And you can very well see if the malleus is fixed in the atic. So, ossicular chain, their integrity, abnormal fixation, all those things you can pick up very well on a good CT scan. Only thing you need to know what is to be seen in what section, what all things to be emphasized and seen in particular disease pathologies. This is very important. So coming to the same point, we are going from upside down. Now, as we go down now, we have seen vestibular aqueduct, vestibule, cochlea, facial nerve, ossicular chain. Now, as we further go down, this is very important. See the cochlea. See all the three turns of the cochlea. Apical, middle, and the basal turn. This is important in cochlear implant surgeries. And see, this is round window. This is round window. This is round window, which is, closing the cochlea from behind. There's a window, there's the membrane closing the cochlea from behind, and this is the membrane, which is the site of, interest in cochlear implant surgery when you, open up the cochlea for the insertion of the implant. And this is very important to be seen in all planes, how the round window is placed, whether it is favorable or not. There are so many things. Sometimes you do a posterior tympanotomy and you don't see the cochlear round window. If you don't see the round window, you cannot insert the implant. If you try to, you may get disoriented. Now, this kind of information, whether it is feasible or not, whether it is favorable or not, is very well seen on CT scan. Now, see, at this point, this is round window and a very faint, this is cochlear aqueduct. Opening very close to the round window, this is cochlear aqueduct. Cochlear aqueduct has a theoretical value. This is never going to give gusher, but this is responsible for spread of infection from the subarachnoid space to the cochlea. Like in pneumococcal meningitis, when the cochlea gets ossified, this is the conduit for the infection to spread from the subarachnoid space, from the cochlear aqueduct, and this ossification starts first in the basal turn, close to the round window, and then spreads to the entire basal turn, then middle turn, and the apical turn, like that. Now, in such patients, at what point of time you pick up, diagnose those patients develop profound hearing loss, and accordingly your surgical technique is directed. If only basal turn is involved, you can drill out the entire basal turn. And if other turns are involved, then you have to do a complete drill out, and multiple electrodes need to be inserted to give maximum amplification. So this is round window. Now, how to see whether this round window is favorable or not? I had a discussion someday with Pasi sir regarding this, whether a particular patient's round window is feasible to be seen through the posterior tympanotomy or not. I'll give you a simple way. I'll show you the simplest way how you can see. See this on the opposite side. This is round window. This is basal turn. This is round window. This is basal turn. Yes. Now, let me show you certain anatomy. This is facial now. See where my cursor is. This is facial now. This is your facial now. Mastoid portion of the facial now. See where my cursor is. This is your chorda tympani at the medial edge of the round axonotary canal. If I draw at this point of time, see this, I take two lines, simple. One line along the chorda tympani anteriorly, one parallel line along the anterior edge of the facial nerve, lateral to the facial. This is facial now. Lateral to this is chorda tympani, lateral to that, medial to that. And if I see through that, coming from here, drilling this bone is the facial recess in between these two. And if I come like this and see straight, what is that? Round window in the basal turn of the cochlea. How favorable it is. You come from laterally drilling the mastoid and then drilling the posterior tympanotomy between the chorda tympani and the facial nerve. And once you open up this space, seeing from laterally, you will straight away, it leads to round window and the basal turn of the cochlea. How favorable it is. You know what happens sometimes? the cochlea rotates. That is a developmental anomaly. The cochlea rotates. If the cochlea or the round window is rotated behind, suppose it is rotated behind, you will not be able to see through this posterior tympanotomy directly. You open up a posterior tympanotomy, if the cochlea is medially rotated, you may not see the cochlea through that, the round window through that. And those are the difficult patients wherein your experience, matters. You need to do some sort of canal mobilization, or you may have to do a subtotal petrosectomy to rediscover the anatomy, and then open up the round window and do the rest of the job. But the feasibility, whether the round window is feasible or favorable to the posterior tympanotomy, can be seen very well through the CT scan. And this dynamic CT scan has an immense value in terms of, finding accessibility of the round window in cochlear implantation. This is a very, very useful information. See on the other side, this is chorda tympani, this is facial now. Two lines, one line along the facial now here, lateral to the facial now, and one line parallel to this. See this, chorda tympani, and what is falling in between if I'm coming from there? The basal turn of the cochlea. See how feasible it is, the exposure of the long axis of the basal turn. You can put a straightforward implant into it, to the round window, if this kind of a favorable situation is there. So this is very important. Now, once you see the cochlea, you need to look at anteriorly. Anteriorly, this is your carotid artery. You have to see this distance between the cochlear lumen and the carotid artery sometimes could be decent. See this bone over the carotid artery, even in the CSM surgery, sometimes the carotid may be prominent, bone may be decent. In cochlear implant surgery, there are reports where the carotid canal was dehiscent, the bone between the cochlea and carotid was deficient, and the implant finally inserted into the carotid canal. That's a disaster. So you need to look at this partition, whether the carotid artery is dehiscent or not. So this is very, very important to know the information about the carotid artery. And then as we go down, this is see, this is cochlea. I am going down, the cochlea disappears, and this is hypotympanum. Now, to know the details of the hypotympanum, you need to go to the coronal section. See, once you are looking at the cochlear implant perspective, middle ear surgery perspective, CSOM surgery, stapes, at the level of this round window, see, there is no jugular bulb over here. No jugular bulb over here. That means the jugular bulb is not that high. If you see in the axial section at this point where you see the round window, if you see the jugular bulb in the same picture, means jugular bulb is so high to have come to the level of the round window. This is very, very important. I will give you examples of what I said, just to understand that how important it is, because sometimes you never know, and you come across surprises if you don't have a CT scan. If you don't have a CT scan, you come across some surprises. Let me show you. Probably this is the patient. Yes. See this particular patient. This is the example of a high jugular bulb, classic example. See at the level of the round window. See how high the jugular bulb is. You never see the jugular bulb at this level, at the round window in the axial section. And if you are trying to open the round window at this level, see on the opposite side, if you are trying to open the round window, one can injure the jugular bulb, which is immediately below. You have to be very careful. The bone that plays, as more the jugular bulb is high, more the bone surrounding the jugular bulb will be thinner. And injury to the jugular bulb is a major complication. And in the cochlear implant surgery, particularly when you are operating on a child, see this child scan you are seeing was 9 months old when I operated this patient. 9 months old, and see this was a high jugular bulb. We took her for the cochlear implantation, we had this information and we could do it because we were knowing this fact that how high jugular bulb you have to deal with. Many a time we have seen jugular bulb even higher than this, going above the round window level, even to the oval window or above the oval window level. And those situations, you have to decompress the jugular bulb slowly by a very slow bipolar, Surgicel, bone wax. You can compress it down by means of Surgicel and bone wax. You can fix it down and you can acquire more space, and then you can do your job, whatever you want to. So this high jugular bulb is one of the very important finding we should know at this point of time. Now, in CSOM surgery, there are many other important things to be seen. Let me come back to the same. Yes, in CSOM surgery, you need to look at a CT scan from different perspective. I've quickly gone through the different perspectives, autosclerosis and CSOM, the cochlear implant surgery. Now in CSOM, you need more information about the editors, more information about the Eustachian tube. See this? See this? This is carotid artery. This is Eustachian tube laterally. If you have disease going to the Eustachian tube, this is Eustachian tube. This is your tympanic membrane. Your information about the editors. This is editors. Information about the ossicular chain. Information about the dome of the lateral canal. See, this is lateral canal. If there is a lateral canal fistula, you can appreciate with this kind of dehiscence of this bone, if there is a labyrinthine fistula or lateral canal fistula. Then the pneumatization of the mastoid, whether it is adequate or not, how you can simply gauge this pneumatization. See, this is the prominence of the jugular bulb, sigmoid sinus behind. This is sigmoid sinus behind. This is the second genu of the facial nerve. Measure the distance between the jugular bulb and the second genu of the facial nerve will give you, adequate idea about the size of the mastoid. This is, see the second genu of the facial nerve. And this is the, see this, 1.5 centimeter, quite adequate from the sigmoid sinus to the facial nerve. So you can have a fairly good idea whether you have a contracted mastoid, whether you have a highly pneumatized mastoid, because those are very important in decision making once you plan cholesteatoma surgery. You are biased toward giving a canal down mastoidectomy if you have a narrow contracted mastoid, because you are not likely to give a big cavity. You can avoid cavity problems. If you have a very highly pneumatized mastoid, then you are biased towards giving an interiorization or intact canal surgery, because if you try to excentrate all cells, which is very difficult, number one, and ultimately is going to give you a huge cavity to manage. And cavity problems are so prevalent, so important, and so frustrating to the patient. So that kind of information you can easily get from this. Now I'll give you some more examples of the abnormalities what we have seen. See, this CT scan is very important in revision mastoid surgeries. Revision surgeries are very important surgeries, and then CT scans are very important. In those situations, window is closed. What happened? Yeah. Yeah. Now, this was from the CT perspective regarding the cochlear implant. There are certain points for cochlear implantation point of view to be seen on MRI. See, this is MRI on screen.
Yes.
To see the feasibility of cochlear implantation, MRI is very important. Very important in the scene whether the cochlear implantation is indicated or not. So what we believe, there is a basic functioning unit which is required for the candidacy of CI for any patient. And that basic minimum functioning unit is a fluid-filled cochlea and an intact cochlear nerve. Fluid-filled cochlea and intact cochlear nerve, these are two important prerequisites which is to be seen on MRI. if something audiologically, some patient is a candidate for cochlear implantation, you have to verify with the MRI whether he is a feasible candidate for cochlear implantation or not. Because for cochlear implantation, you need to stimulate cochlea. And for that, cochlea must have fluid. For the implant to go in the cavity, it must contain fluid. So see, this is heavily T2 weighted imaging. And what you see is all the 3 tons of the cochlea. And what you see bright inside is the fluid. So on heavily T2 weighted MRI, if you have a good fluid signal in the cochlea, that means a good candidate. Then dynamically you see, look at the nerve. See the 7th, 8th nerve complex. This is the cochlear nerve going to the cochlea. This is the vestibular nerve going to the vestibule. So here you can see dynamically how is your cochlear nerve. See this very clear? Integrity of the cochlear nerve and the fluid filled cochlea. These are 2 things which must be seen on MRI before doing any implantation. Now the 3rd thing, regarding the cochlear nerve, what I am doing is a reconstruction of this MRI. What I am trying to show you, the cochlear nerve, whether it is a thin cochlear nerve or adequate cochlear nerve. So what I am going to show you, this is, see, in the sagittal plane. This is sagittal plane. There are 4 nerves in the intra-auditory meatus. See, in the dynamic, this is the only way to see. This is your cochlea laterally. This is the cochlea laterally. And from there, the 4 nerves emerging. See this. This is intra-auditory meatus. 4 nerves. See this. This is your facial nerve above, cochlear nerve below, and these 2 vestibular nerves behind. This is the cross section of the MRI on sagittal sections. This is facial nerve, cochlear nerve, and the rest of the 2 vestibular nerve. And what to see on MRI? Whether the cochlear nerve is hypoplastic or thin. How you can have a fairly good idea? This is facial nerve. This is cochlear nerve. If this cochlear nerve is less in dimension than facial nerve, it can be considered as a hypoplastic cochlear nerve. Normally, cochlear nerve diameter is bigger than the diameter of the facial nerve. On MRI, if this cochlear nerve diameter is less than the diameter of the facial nerve, it can be considered as a hypoplastic facial nerve. So these are the 3 things we must see in the MRI before any cochlear implantation, besides any other bigger anomaly or tumor in the, the brain which can affect your hearing consequences. That is another thing, like a acoustic neuroma or something, and other tumor which can impact the hearing outcome. Besides that, so MRI is very important. Cochlear implantation, in CSOM and other thing, the CT scan is important. So how to look at CT, MRI, all these things are important. Now some examples. I am giving you some examples which needs to be, discussed one by one. See, one of the these examples I always mention. This particular example, many a times post-mastectomy, you will see a lot of patients coming with a discharging cavity. Discharging cavity has many reasons, we all know theoretically. High facial raise, inadequate meatoplasty and other things, which you can see from outside. But there are things to be seen inside. The 3rd dimension has to be seen. And that is that what kind of a mastectomy done by the previous surgeon. CT scan will tell you if you have done a canal down mastectomy. See on this right side, this was a discharging cavity. The surgeon has done a canal down mastectomy, persistent discharging cavity, and the region is very obvious. Incomplete exentration of so many cells. These cells containing mucosa is persistently discharging, secreting because of unaeration. So once you are doing a canal down, and if it is a persistent discharging cavity, once you get a case of canal down done, you must look at this third dimension, that how the cells have been excentrated. Many a times, the hypotympanic cells and the cells in the petrous apex are responsible, and you need to thoroughly drill them away. See how many cells are left behind and a cavity is created. So this is, I would say, a classic example of the incomplete job done, and we must assess with a CT scan, and then you can plan which cellularity is left behind, how much to excentrate, and how can you deal with this situation. You can deal with that or not. This is very, very important information where we get from this thing, CT scan. Now, another information. This is very important. These days, as we get a lot of, revision cases after CI surgery, explantation, examples of explantation after CI surgery. See this. And the thing which we always miss is the hidden disease. Like I tell you, children are the most important candidates for the cochlear implantation. What happens if there is an implant in place and the child develops otitis media, CSOM, or any other infection? A foreign body is in the place, in the vicinity of the infection, prevents infection to cure, number one. It makes the antibiotics ineffective. And once the foreign body is there, it can develop biofilms, and then all your antibiotics and everything becomes ineffective. So, and ultimately in majority of those patients, explantation is the final choice. And that's a disaster. Disaster for the patient, for unnecessary surgery done, and the cochlea, ultimately you have to explant the cochlea, may not be, viable for the next implantation, and the cost involved and all that. And you know how it is overlooked? Look at the CT scan. Look at this baby. She's 1.5 years old. 1.5 years old. Simple history of recurrent, 2 or 3 episodes of secretory otitis media, minimal secretory on otoscopy. Now what happens? Secretory otitis media is mostly because of the nasal issues. Could be Eustachian tube, could be adenoid, could be sinusitis, whatever. If this part is overlooked and this child is implanted, what can happen? The infection can again take place, and then the implant can get involved. Now, look at the paranasal sinuses of this child. Small child. Look at all this. Massive sinusitis. Massive sinusitis. I will show you the coronal. See, the sphenoid and all not developed. Frontal not developed. Because she's a very, very young child. And look at the maxillary sinuses. Look at the ethmoids. Massive sinusitis. And if such children implanted and the infection then turns back, what is going to happen? That's a disaster. So, in all these children, when you assess for the cochlear implantation, we must assess for the nasal causes. We keep under loop, under high scrutiny for patients who are having, or you can say, who are high likelihood to develop otitis media, like patients with, cleft palate, who have a malformed Eustachian tube muscles, patient with recurrent SOM, patient with massive sinusitis, which is hidden part. Normally for such children, we don't get CT scan for the sinuses, and one can easily overlook. And if that kind of a massive problem exists, we do in such patient, these are the ideal gold standard indications for the subtotal petrosectomy implantation. What do we do in that? This patient was implanted after in the same stage with subtotal petrosectomy. What do we do? And why do we do that for? Why this CT scan is, forcing us to do that? In subtotal petrosectomy, you excentrate all possible air cells from the temporal bone and block off, remove all the mucosa and skin from the temporal bone, extrauterine canal everywhere, and block off all outer connections from the temporal bone for the infection to come into. Since after cochlear implantation, your middle ear and mastoid and axonotary canal are not going to participate in the hearing. So you can ablate the middle ear, external ear, everything, because your implant is directly stimulating the inner ear hair cells. So in subtotal petrosectomy, all this skin, mucosa, everything remove, all cell excentrated, and both the outer connections, means connection through the eustachian tube and is blocked, and the cul-de-sac closure is done from outside, and the entire cavity is obliterated with the fat. So your implant resides in a new cavity covered by the fat, which is a sterile zone, which all external connections blocked off to prevent entry of infection to that region. Means by means of blocking the eustachian tube and the axonotary canal. So these are the ideal candidates for subtotal petrosectomy implantation, and these are often overlooked. I am not saying these are not common, uncommon. This is not uncommon. We have seen a couple of cases, and particularly nowadays with when the government schemes are prevalent, the free cochlear implant surgery being done, we have to be 100 times more choosy about it. We should not overlook. We must thoroughly assess on CT scan and clinical grounds which are the patients who are high likelihood to develop, infection later on, and in those patients we can go ahead with the subtotal petrosectomy implantation in one go, preventing all possibility of future infection in the implant zone to direct us explantation. This is so important and information from our perspective. Cochlear malformation, we have to be careful and accordingly choose our technique. I am not going in details of the cochlear malformations. Now we have how much time left to throw some lights regarding tumor? 20 minutes, sir? Yes.
Yes, sir.
So I will just take you through some of the important situations of tumors of the temporal bone, whether the radiological imaging is as a significant role. Just a minute. One of the important tumor are, I will take you through some important situations. One of the important tumors is the glomus tumors. Diagnosis of the glomus tumors is very obvious many times on clinical grounds by means of seeing a vascular mass lesion in the temporal bone. See this. This patient. So the diagnosis is rarely a challenge in glomus tumor. And see, there are two types of glomus paraganglioma. Glomus or paraganglioma, there are two types of lesion. Jugular paraganglioma, tympanic paraganglioma. We must differentiate in between these two. Jugular paragangliomas arise from the jugular bone and ultimately grow into the jugular bulb lumen and block the jugular bulb. See, this is a classical example of jugular paraganglioma with lot of flow void. This is a contrast image, lot of flow voids into it. These are all vessels. And see, this is your jugular, see this is your sigmoid sinus, transverse sinus, sigmoid sinus, and ultimately this is the jugular bulb region which is involved by the tumor. MRI gives you adequate information about the diagnosis. See the glomus jugular enhancing tumor with lot of flow voids, relationship with the carotid artery anteriorly, planes to separate from the carotid artery which cannot be seen on CT scan. MRI has various sequences that gives you adequate information whether the tumor is in contact with the carotid artery, tumor is involving the wall of the carotid artery, and how much the tumor is engulfed the carotid artery, which dictates you to do further studies on the carotid and the cross flow. This is very important, which kind of information you get from the MRI. Second thing, the other sequence on the MRI we show you is the T2 weighted imaging. T2 weighted imaging again shows you all the flow voids. Look at the flow voids here in the T2 weighted imaging. Look at the flow voids. Look at these flow voids in the T2. This is classical of the jugular paraganglioma. This is very, very important information we get from the, in these glomus jugular tumors. See these are the big vessels. These flowoids are vessels. These are large vessels in the tumor. And now, third information we must order, third investigation is the CT angiogram. CT angiogram will tell you each and every, vessel going into this tumor. See, this is the tumor. This is the tumor. I am not going into details, but if you see carefully in the neck, this is common carotid dividing into external and internal carotid. And from there, what vessels, you can trace each and every single vessel going from there to the tumor. See, this is the external carotid going behind, and from here, this is the external occipital artery which is given off and giving a big supply to this tumor. So you can get to know amazing information about all the vessels going to the tumor if you have time and trace each and every individual vessel, so that during surgery, before handling the tumor, you can block off all those vessels and devascularize to certain extent these tumors. So this is very, very vital information. I would say you can get from the MRI and the CT angiogram. Another important is the simpler glomus tympanicum tumor. Glomus tympanicum tumors can be diagnosed as a mass behind the tympanic membrane, but the best and the most relevant surgical information what you get is through the MRI. Most relevant information. Okay. See this. This is the MRI of a patient of a glomus tympanicum. Now, how to differentiate the tympanicum from the jugular? See this MRI. This is where my cursor is. This is sigmoid sinus. Sigmoid sinus. I am following the sigmoid sinus, and this is jugular bulb. This is jugular bulb, and know where my tumor is. My tumor is where? See, tumor is here. Tumor is here in the middle ear. Nothing to do with the glomus, jugular bulb. This is the tumor which is prolapsing in the eustachian tube, which is no attachment in the eustachian tube. Now, what kind of information do you want to know in these tumors? Whether they are extending to the mastoid so that you can plan a mastoidectomy approach, whether they are going to the atic so you can accordingly plan an atic approach. So what you can do, you can reconstruct and see each and everything where this tumor is going. See this. See my reconstruction. Now see, this is the tumor. This is in the sagittal plane. This is the tumor going into the atic. See, this is the atic region. This is the tumor which is not going in the hypotympanum. See now, this is jugular bulb in the coronal plane. This is jugular vein. This is jugular bulb, jugular bulb, jugular bulb, jugular bulb, jugular bulb. See sigmoid sinus. But the tumor is above the jugular bulb. This is hypotympanum. This is mesotympanum. This is epitympanum. So in glomus tympanicum tumor, you can get to know all the information where the extension of the tumor is, what kind of the vascularity is supplying the tumor. Other examples quickly, because the time is, the constant. Acoustic neuromas, one of the most, I would say, common tumors in our practice. Acoustic neuromas are common tumors in our practice, and we must know. Okay. Which is that? This one? Yes. So these are common tumors in our practice, and we must know what kind of tumor, whether it is acoustic or not. See, this is MRI. This is T2 weighted MRI. This is very important in diagnosing acoustic neuromas. You need lots of sequence of MRI. CT scan cannot diagnose acoustic neuromas. See on MRI, this is your T2 weighted, heavily T2 weighted imaging. This is your contrast. Classically, acoustic neuromas are hypodense on T2, but hyper intense on contrast. This separates or differentially diagnose the acoustic neuromas from other tumors like cholesteatomas, glomas, and other. See, this is classically hypotension T2 extending from the CP angle into the intra-auditory meatus. See, always they extend into intra-auditory meatus, enhances on contrast, and heterogeneous texture. Heterogeneous texture means there are internal necrotic areas. That is classical for acoustic neuromas. So, acoustic neuromas require a lot of information from MRI in surgical planning. For example, see this simple information. This is the tumor, and this is the lateral part of the intra-auditory canal which is not infiltrated. Such a vital information. This is CSF. CSF lateral to the tumor. These are inner ear, the cochlear vestibule. Then in the lateral most part of the canal is the fluid, that is CSF, and tumor is medial. So this is the classic case where the tumor has not infiltrated the inner ear. If it has infiltrated the inner ear, you need a more extensive approach, involving ablation of the inner ear or the middle ear. Otherwise, most of the time they can be managed with a translabyrinthine approach. Translabyrinthine can remove any size tumor. Size doesn't matter. See, our access to in the translabyrinthine is direct from lateral head-on approach. And the first thing what we see is the intra-auditory meatus and the facial nerve. So out of all the approaches, the translabyrinthine gives you the best opportunity to identify and positively at the beginning of the surgery when you open the intracaustic meatus to identify the facial nerve and preserve it later on. Then there are, variety of difficult situations in acoustic neuromas. You can come across acoustic neuromas sometimes are cystic. They pose a lot of problem, and the peripheral cysts are difficult to remove in those situations. See, this is acoustic neuroma, which is purely cystic. Purely cystic, and this is very important. See this tumor. Yeah. See this. This is the tumor, and see there are inside the tumor multiple cysts. Multiple cysts in the tumor. This is acoustic neuroma, and there are multiple cysts in the tumor. And this cyst, once they come to the periphery, it is so difficult to separate the cyst wall from the neurovascular structures in periphery, and ultimately you have to leave it to protect the structure. So what kind of acoustic it is, you can differentiate from MRI. MRI gives you complete information about that kind of tumor it is, whether it is completely removable, what approach is required, how are the, the brain it is pressing on the ventricle, giving hydrocephalus, so many other things. All this information you can get from the imaging. Imaging is so vital in those situations. So imaging, few more examples before we, finish in our time. This is so important. I can give you some more examples of the temporal bone malignancies, how to take decision making in malignancy temporal bone. This is very, very important in certain situations.
Satish, show some trauma patients.
Trauma
to the temporal bone.
Trauma, I have to find out because they may be in some other folder. It may take time, but I forgot to include the trauma. I should have included. You're right. But yes, in trauma, you can see the facial now. I understand why you're asking. From which point of view?
Sir, there is a lot of trauma patients in the emergency as well as in the OPD, and how to manage them, and what checklist we should see in the trauma temporal bones radiology.
Yes. Your point is valid. We must see, CT scan thoroughly in trauma patient when they present with facial palsy. This is very, very important, to see the trauma patients. Let me show you if I get some temporal bone malignancies. See, this is a classic example. Recently, we diagnosed in a doctor himself. The patient was a
Sir, I have a temporal bone trauma CT. I'll just share it after 5-10 minutes after I download it.
Pardon?
Meanwhile, sir, I can share a temporal bone trauma CT in 5 minutes after I download it. Then we can read that one.
Yeah. We can discuss.
Yeah.
Sure, that's a great idea. Because mine can take time to find out the trauma CTs. This was this patient was a doctor. She had a mass in the mastoid. Can you see this? This was a mass in the mastoid. Now, whether it is malignant or not was a big question. He presented with a facial nerve weakness because the mass was lying in the region of the facial nerve, but still not sure whether it is, malignant or not. So we got a diffusion weighted imaging, and diffusion weighted imaging completely cleared up whether it was, you can, in those situations, you can confidently say with a diffusion restriction, if I get the image of the diffusion weighted imaging, I always emphasize on that, is a very, very important imaging by means of which you can almost always with certainty rule out a malignant lesion. Because this lesion, if it is showing restriction on diffusion, is more likely to be malignant. This is so important. That was a different sequence, not this one. So on CA temporal bone, you need a lot of information from, MRI or CT scan. From imaging, you need, yes. There's another patient. See, in CA temporal bone, surgery we all know is a big challenge. It is not commonly practiced for the region of the anatomy. I give you an example of this patient, particular patient. See, this resectability in temporal bone malignancy is a big question, and MRI is the key to see the resectability. The reason being the close proximity to the important structures. Now see number one behind. This is your transverse sinus, this is sigmoid sinus, and this is jugular bulb. All intact. The tumor is here. The tumor is here away from the entire jugular venous system, number one. Number two, the carotid artery is here. Carotid artery is there. It is away from the tumor mass, whether it is involving middle ear, inner ear. Third is the facial nerve, which is immaterial in a malignancy, but is involved. You have to resect an anastomose. That's a different issue. Here in the malignancy of the temporal bone, if you don't get the proximal end, the end of the brain side, you have to, anastomose with the other nerve, like we do commonly with the mesenteric nerve. So here, resectability of the temporal bone malignancy is best seen on MRI, where the involvement of the carotid artery, involvement of the jugular venous system, involvement of the brain, facial nerve, everything you can get to know perfectly, so that you can still resect such lesions. And we have a now huge series wherein we have done, lots of temporal bone malignancies on the basis of MRI. MRI is the thing which is most important, which is decision making in those patients. Yes? Hello? Hello?
Sir, you're audible. You're audible, sir.
Yeah. I thought there was some question.
No, sir.
Now, see, this is another example of an interesting patient. Sometimes, see this child, look at the age about 2-year-old. 2-year-old child with such a massive tumor. Your MRI will tell you resectability. See, this is like a cricket ball in the head. Such a massive tumor of the ipsilateral temporal bone entire temporal bone is replaced by the tumor. See, this is the normal temporal bone on the opposite side. This is the temporal bone on this side. Entire temporal bone is replaced, but you know the planes with the brain intact. See the plane. Planes with the brain intact, planes with the carotid artery intact. Planes with the carotid artery absolutely intact. Planes with the sigmoid venous system absolutely intact. In spite of having been a huge tumor, this is chondrosarcoma, malignant tumor, 2-year-old child, yet resectable and we resected, and patient is doing fine. So your MRI can give you the exact information of the resectability. It's not the size of the tumor which matters. It is the involvement of the critical structures which matters in when you talk of resectability. So there are so many things, lot to go, but I know it is 8 o'clock, so I have to be, respecting the time. If you want me to continue, I can show a couple of examples, or we continue with the question answer.
Dr. Satish,
Yes, boss.
can you tell our audience the checklist of HRCT temporal bones? What we should 1, 2, 3, 4. What we should take care of this thing?
Yeah, so it depends, boss. I mentioned, yes, your point is valid. It depends upon the pathology for which you are looking at the CT scan. Like when you think of atherosclerosis, when you are operating on atherosclerosis, you need to look at different things. When you are operating for the CSOM, you need to look at different things. When you are operating for cochlear implantation, you need to look at different things. When you are operating for a tumor, operating for a cholesteatoma, so your concerns are different for different. So for atherosclerosis, for example, we are least bothered about the pneumatization of the temporal bone. We are least bothered about aeration and other issues. We are more concerned about the facial now. We are more concerned about the inner ear if giving gusher or something. So the things are different according to the different pathologies, boss.
So we understood, Dr. Satish, that the checklist is different for different conditions.
Yes, boss.
Here I would like to thank you, Dr. Satish, especially last week only for the information of all those who are listening. I was stuck in a cochlear implant on a small child, and this was due to non-visibility of the round window niche due to extensive thick bone and overgrowth of the bone around the round window niche. Dr. Satish has already shown you one CT in which he has pointed out that round window niche may be obscured only because of the high thickness of the bone around the niche, especially the anterior lip area. So I want to thank you, Dr. Satish, for the timely consultation and help in that particular child.
It's a pleasure for me, but that was a real interesting situation, sir, with a lot of people overlook. And in your situation, it was not the pure visibility of the round window which was the concern. In your situation, the round window niche was very thick.
Yes.
Which was obscuring the round window. It was not the round window rotation which was creating problem. The niche was too thick. It could be appreciated very well on CT scan. And once you see on CT scan, the thick round window niche, you can, freely drill it off to expose the round window. That was a very interesting situation, sir.
So why I raise this issue is only to convey that you can be stuck at any point of time, at any stage, and what is the importance of knowing the anatomy and the findings in particular situation on a complex temporal bone.
Yeah. So
Dr. Satish, I have a small question for you.
Please.
Everybody wants to know about the software.
Yes.
So on the DICOM,
yes, sir.
How much does it cost and how to procure it?
Yeah, you can buy online. There is a trial version for some time. Then they charge a subscription of 5 years or something for say 15,000. I don't remember exactly now, but 17,000 for 5 years.
Okay, it's not that expensive.
Yeah, but this this platform gives you ability to see all sorts of scan on the planet. CT, MRI, cone beam scan, PET scan, all scans
Okay.
can be seen on this with so many, there are so many things to be seen, various windows settings. You can measure the sub-millimetric structures. You can convert to 3D. You can convert to bone. So many things you can see. See this? I can convert to bone, whether how it is, you can look at all the aspects. So this is a very, very important, tool to give us ability to see the surgical details in all three dimensions, which radiologists don't give. The only issue is we need to learn ourselves. If you want to know which vessel is entering the tumor, you would like to know how it is entering into the tumor, like in acoustic neuroma, we see how the facial nerve is related to how it is entering post-anteriorly, anterosuperiorly. Those vital information cannot be gained from the radiologist's report. They never mention all that in detail. They're too busy to do other things. So they are more or less, sort of technicians in terms of giving a limited information. For surgical details, either you have to have a good liaising with the radiologist to be, to stay in one-to-one contact to get each and every information in detail for every patient. If you have that kind of a rapport liaising with the radiologist, otherwise you have to learn yourself, and this makes a difference in your practice, because many a times otherwise you come across surprises. By means of radiology, 99% of the time, you are quite confident in tumors, particularly what exactly the tumor is, so you can plan accordingly, counsel your patient accordingly, plan your approach accordingly, avoid the complications accordingly, and convince for the possible complication to the patient. Otherwise, you think something, it turns out to be something else, and then everything becomes a mess. So it's very important.
True.
Dr. Satish, I have got a question.
Yes, please.
This is for the benefit of residents.
Yes,
That
sir, please.
like, should we forget about X-ray mastoids presently?
The X-ray mastoids do not give.
Because why I'm
the
asking this question is,
Yeah.
for postgraduates, and we do ask them as examiners. I've been examiner for donkey's years now. We do ask. The things have changed. I know there are things like in our college also now CT scan and everything is available. But there are certain situations in which CT scan might not be available. I'm talking of CSOM cases. I'm not talking of special cases like acoustic neuroma and all. That is altogether different situation. CSOM, squamosal type of disease. Is there any role still left for X-ray mastoids?
Hardly any. The X-ray mastoid can give you limited information of pneumatization.
Yeah.
That's the only thing. Like rest of the things, the way we look at the CT scan regarding the entire course of the facial nerve at every level, relationship with the brain, relationship with the tegmen, inner ear, now cannot be differentiated on X-ray. X-ray gives a limited snapshot information regarding the overall pneumatization, nothing more than that.
So in cases of CSOM, squamosal type and all, we should go in only for
Most of the
HRCT temporal
time,
bone in uncomplicated cases I'm talking
in
of.
uncomplicated CSOM, particularly in perforations, squamosal type, even the CT scan is not going to be very useful in terms of giving additional information, in terms of giving decision-making information. It is more useful in cholesteatoma and other situation where you need to see the third dimension which is likely to be affected. In cholesteatoma, how it is extending, you have to plan an intact canal down, you have to look at facial nerve, you have to look at labyrinthine fistula, you have to look at tegmen or sinus erosion. Those vital information is given by CT scan, and that's why it is more useful. Then in squamosal otitis media, where all this information is of no relevance. So it is more important in unsafe cholesteatoma disease than in a safe disease.
So in other words, like radiology has got no role in commercial uncomplicated disease.
Hardly
You have to
any.
open up and see. You have to
Yes,
open up and see yourself.
yes, yes.
So please, residents, note down this answer. This is coming from Dr. Satish Jain. You can quote him in the exams also. Can I, Dr. Satish
Yes,
Jain, can I take this liberty
please,
of getting
please,
you
please,
quoted during the exams also?
please.
Okay, thank you.
Sir, so Ashima ma'am is ready with the HRCT of temporal bone of the trauma case. So
Hello.
I request Satish Jain sir to please unshare your screen so that ma'am can share the screen now.
Yeah, yeah. Please share on the screen.
So you'll have to
Stop sharing, sir.
you'll have to stop
Okay,
sharing and
okay,
then
okay.
it will start sharing.
Yes. Now I can see. Yeah, I can see. See, in trauma, you need to look at few aspects. Most of the time, it is related to the facial nerve. So there are fractures. You have to define how the fracture line is going. According to the, velocity and the direction of the injury, the fracture line is defined. Yeah, see, if the fracture line is parallel to the long axis of the petrous bone, see this along the long axis of the petrous bone is longitudinal fractures, and most of the time your facial nerve is spared. If the fracture line is across or perpendicular to the petrous bone, then it is likely to involve the facial nerve, very often an immediate palsy. In indirect, oblique or longitudinal fractures, most of the time facial nerve is spared. If at all injured, it is at the level of the first genu where the facial canal is affected. Now, for the decision making, whether the facial nerve decompression or facial nerve treatment is required, it is the clinical course need to be taken into consideration. By and large, any facial palsy which is developed immediately after the trauma is likely to have involved the facial nerve and which requires some sort of, treatment immediately. And those facial nerve palsies which develop later on after the trauma in longitudinal and other fractures because of the edema in the facial canal or some hematoma developed, and all those are predominantly conservatively managed. Now on CT scan would help further here in those situations. If some bone piece or bone fragment is involving compressing facial nerve, if some hematoma is developed which has swollen up the facial nerve, all those things you can see on the CT scan. And in those situations, even if not having a transverse fracture, in those situations, still there you can find the indication for decompression or surgical treatment. So the CT scan is very important to define the kind of fracture, the involvement of the facial nerve. I've shown you in the previous CT scan how to look at the facial nerve right from the first genu to the stylomastoid foramen. So the kind of fracture line the particular patient has an impact on the development of facial palsy and the need of decompression or any other further treatment.
Sir, here I would like to add that
Yeah.
there is
See this fracture line across the labyrinth. Can you see this patient? See this fracture line across the petrous bone. Yeah, stop here, stop here. Go back, go back. See this transverse fracture. Can you everybody see?
Yes.
On the right side, this fracture line across. And if you go down, now you go down, you will see where the fracture line is passing through at the level of the facial nerve. Down, down, down. Now see the fracture line passing through the horizontal or the second genu. See where your cursor is. See this? If such patient presents with a complete facial palsy at the time of onset, is the patient for immediate exploration. Many times you will find the fractures in the facial canal, yet facial nerve being intact. with some hematoma or fracture segment compressing on it. And these are the cases, even if you have in the most massive injuries, transactions, you can, this is repairable because this is in the middle ear, epitympanum. So the CT scan is decisive in these situations, what to do, when to intervene, and what kind of intervention is required.
So there are 2 points from my side in facial nerve paralysis.
Sir.
Because as you know, I had been dealing with military accidents and
Sir.
aviation injuries and all. First point, as you very rightly said, immediate onset, complete paralysis. So the dictum is IOCP. If you remember, this is for postgraduates. Immediate onset, complete paralysis, immediate exploration. Am I wrong, sir? Right?
Yeah, you're absolutely right.
Absolutely right. Now the thing is that most of the time, head injury patient, road traffic accidents, aviation injuries, these come to us as a referral cases. The history is very important in these cases. And as soon as you elicit the history and the head injury part, the patient is absolutely fine. You please explore the patient. Second thing is, like you have rightly said, longitudinal versus transverse paralysis. It is very well mentioned in Scott Brown's earlier. When I was a student, MS student, I think we had fourth edition of Scott Brown. Very nicely mentioned longitudinal fracture versus transfer fractures. Transfer fractures, cochlear injury, facial nerve injury, longitudinal this thing, conductive hearing loss. In other cases, it was sensory hearing loss with facial nerve paralysis. This is I'm talking of for the benefit of postgraduates. Thank you.
So do we have some time for some
Yes, sir.
questions? There were some people who had asked some questions.
Yes, please.
Now we can take 1 or 2 questions.
Hello.
We
Hello.
have 2 questions, sir.
Dr. Raman.
Hello.
Dr.
Good
Raman, I
evening.
am
Good evening, sir.
Hello.
Anna, sir. Good evening. We
Good
welcome
evening,
you.
sir.
Dr. Satish Jain. Good evening, Dr. Raman and everyone. I must congratulate the association as well as you young guys. Dr. Satish Jain is a master class, and one take home message is that you must have a good trust with your radiologist, because they are not busy, but they don't know what you need. So everyone should have a very good trust within your X-ray person, your radiologist. So both of you learn on the way. So wonderful. Congratulations again to the whole team. Dr.
Thank you very
Satish,
much.
how are you?
Fine, sir. Thank you.
Wonderful, wonderful. Go ahead.
Dr. Satish, I have got a personal question with you.
Please.
Sir, can I do my MS again under you, sir?
Okay, sir. Pleasure working with you. And for such comment,
I'm a 65 years old person.
God.
I don't know how I can get into another MS2, I can call it as, because that will be more beneficial for my second, incarnation. Probably I will be born as a ENT specialist. I do pray to God that I will be born as second ENT specialist in second janam jo bolte hai usko.
Sir, there is no
Thank you very much.
Why do you worry about the degree? You want to enhance your knowledge.
No, I want to enhance my knowledge. Degree is immaterial at my stage.
Yeah.
I've got a lot of degrees and lot of medals and all, everything. So I think that is immaterial for me. But the way Dr. Satish Jain has presented and the surgeon he is, so I think everybody should be like that. Thank you.
Thank you, sir.
So on behalf of Haryana State AO, I extend my sincere thanks to Dr. Satish Jain for spending the valuable time and sharing such an informative lecture with all of us. And I'm sure that everybody whosoever has joined is immensely benefited by this talk. Thank you so much once again.
Thank you all. Thank you all once again for giving me this opportunity Thank you once again.
So, thank you very much, sir. For Dr. Ashma, our second moderator, ma'am, you want to say something?
So we were just asking if there were 2-3 questions for you. So if you had time, you could just
Yeah,
finish
please,
them.
please.
Sir, one question was by Dr. Mandata that what do you do in a case of persistent stapedial artery? Do you have to abandon the surgery all the time or can you do something?
Yeah, so that's a very interesting situation. I have come across such situation 4 times in life. You know, the first time when I came across, I didn't have a CT scan that time done before. And when I saw the persistent stapedial artery and it was in my field, and ultimately, in order to do the surgery, anyhow, I coagulated and went ahead and did the surgery. Unfortunately, nothing happened. Then I went to literature to know what exactly I did. Could it have any repercussions, any complications, or anything? This artery is destined to supply some intracranial structures if it is persistent. Normally, it is absorbed by the 10th week of gestation, and this function is taken over by the middle meningeal artery. If it is persistent, it is destined to supply some areas. If it is important area, it can lead to infarction or complication or something, and it has been reported. So after that, our approach is changed, and nowadays, in 2 patients, we could put the piston besides the artery without coagulating the artery or without removing the artery or anything. Saying little gentle, preserved the artery and did the stapes surgery. In 1 patient abandoned, having the fused vessel. Fused means the entire obturator foramen between the, both the crura was obliterated by the artery. So nowadays, we are abstaining from coagulating the artery with the fear that it might be supplying some areas and which should be respected.
Thank you, sir. So the next question is radiologically, what is a high riding jugular bulb?
High riding jugular bulb definition.
Yes, sir.
You know,
Radiologically.
yeah. So radiologically, you can see in coronal section that how much high the jugular bulb is going. If it is coming to the level of the round window, it is considered high jugular bulb. If it is going further above the level of the round window, reaching to the level of the internocostic meatus, then it is considered very high rising, and this is very important, not only in the middle surgery, but in lateral skull-based surgeries. Initially, it was considered to be a contraindication, but nowadays, believe me, it is no more a contraindication. You can reduce your jugular bulb down, as I said earlier, by means of removing whatever thin bone over it. More high it is, more thin the bone or boneless it is going to be, not covered by the bone, only periosteum. And in that situation, you can, by means of using your periosteum elevator, you can push it down, then taking the help of, the surgery cell and the bone wax, and then above that, the periosteum elevator, you can keep pushing, and with the bone wax, you can fix it down. So it is no longer a contraindication in those situations, provided you have a good exposure, like subtotal petrojectomy or something to deal with the bleeding in case happens to occur. But radiologically, you can pick up very well on coronal section, a jugular bulb, that how much high it is going. And accordingly, you have to plan your surgical approach and counseling.
So one last question is there for you. Is there any advantage of endoscopic stapedotomy in case of persistent stapedial artery?
See, endoscopic stapedotomy is a new approach. As wherever the endoscope is being used, more and more, options are being explored. So advantage of endoscopic stapedotomy is to give you exposure by means of without too much of drilling or removal of the overhang. That's the biggest advantage to get with the endoscope, because in microscope, you cannot get a linear view unless you remove the overhang. In endoscope, with a wide angle endoscope, you practically don't need to remove too much of overhang, and you can go ahead doing stapedotomy without doing that. Now, but that is a 2-dimensional visualization, not a 3D like microscope. Now coming to the stapedial artery is an anomaly coming in the way to the foot plate. Here endoscope or microscope is nothing is going to matter. So in cases of persistent stapedial artery, endoscope has no practical, special relevance. Endoscope, microscope, same. It is the artery which matters.
Thank you very much, sir. You're a true teacher that you're taking questions long after the formal talk has ended, and you're always enthusiastically answering all kinds of queries. It was so lovely to hear you. It always is. Before the start of any surgery, we actually wait for the time when the case is getting induced and you tell about the radiology. And no matter how many times we hear your lectures or see you on the YouTube links, it's always something more to learn from you.
Thank you for your attention, your involvement, and it's really pleasure association. Always, associating with the Haryana people, Haryana AOI, Haryana workshops, conferences. It's like, our own team we are working with. Thank you so much once again, everybody.
So thank you very much, sir. So thank you very much for enlightening us with the ocean of knowledge you have on the radiology of temporal bone. And sir, every time we have many videos on YouTube, but every time, as Dr. Ashima said, every time we listen to you, we get something new out of it. So thank you very much, sir, for taking out your time. So we are going to have our next radiology session on 19th, the last radiology session on head and neck by Dr. Jyoti Kumar. So today I want to conclude. Before concluding, I would like to invite Dr. Rupender Ranga sir as representative of Haryana AOI to say a few words, and then we can call it a day.
I think it was the well conducted and well attended Zoom meeting on the temporal bone anatomy and radiology. And I am very thankful to Dr. Satish Jain for teaching this radiology in a very simple manner. Dr. Satish always very keen to teach ENT, radiology and surgical procedure in a very simple manner. Even though Dr. Satish busy on the 12th, and he asked me to prepone by 11th. That's the reason we have planned for this today.
Yes.
Dr. Satish Jain, don't deny, we will not do. He asked me to prepone. I'm thankful, Dr. Satish.
And all thanks to you, boss. All thanks for your kind consideration.
And Ashima for this moderating this session. And I am thankful to Dr. Raman Sharma, JC Pasi, the brain behind this show. I'm thankful to all the all the doctors who log in this Zoom meeting today. Good night, everyone.
So today we have crossed the century. We have made a century. More than 100 participants were there.
Okay, congratulations.
Thank you. Say congratulations. So thank you, sir. Thank you, everyone. Good night. Good night, sir. Thank you.